Hi, everyone. Thanks to the Academy. My name is Javier Jimenez. I'm the director of CL Psychiatry at Long Island Jewish Medical Center, part of Northwell Health. I'm going to be speaking about something very related, actually, to what has already been presented on, so it's a nice segue. A concept, post-traumatic embitterment, that is not necessarily part of our lexicon, maybe yet. And I think it's helpful for us when we're conceptualizing the so-called difficult patient, which still is in our lexicon, unfortunately. Um, I have no disclosures related to this work. You might have seen another name on there under mine. That's Dr. Chernishkova. Just go back for 1 second. I'm indebted to her. She's actually a former CL fellow in our program who is now attending in Connecticut, and she brought this concept to my attention when we were working clinically. And I'll unpack it in a second. So again, to set the table, we are tasked with some challenging situations in our line of work. That's no surprise. Actually, 10 years ago, I remember doing a pre-conference workshop at the Academy with a number of other speakers on the difficult patient, and it was a 4-hour session talking about all the different psychotherapeutic modalities and diagnoses and all of that. Today, I'm going to just focus on one element that might be at play in the so-called difficult patient. Much of the attention has been sort of directed at personality traits, disorders, diagnoses, DSM categories, things like that. And then, of course, other frameworks like countertransference, of course, other diagnoses. I'm not going to focus on that. The alternative view that I'm going to talk about today is not mine. It's something that is borrowed from other scholars, actually from the old world in Europe. The idea that somebody may have long-lasting embitterment, which we'll unpack, secondary to either medical trauma or some other insult, and that is informing, to a large part, the so-called difficult behavior or experiences that we're encountered in. So one definition of embitterment is that this important feeling. Sorry, the definition is coming up, but this all led to this development of a diagnostic construct, not in the DSM, of PTED, we'll talk about. So what is embitterment? Embitterment refers to, of course, this difficult, angry state. Individuals may present phenotypically, like we were just describing, refusing help, communicating frustration, hostility, anger. It can even, of course, feature suicidality, homicidality, or at least the expressions of that. The common theme described here is a loss of something, right? Some deep injustice that has led to this. And that's important for us as CL psychiatrists, I would argue, to identify in given patients. This phenomenon, psychological construct, whatever you want to describe, has been seen in a number of populations, not just medical, immigrant populations that have lost much. It's been studied formally in different ones, so I have references for those who are interested. The adolescent, and certain actual DSM diagnoses. So you can see how it's being looked at across clinical and non-clinical populations. And even in the medical setting, we're starting to see literature describing this in certain diseases that we, of course, treat. I'm not going to read them all there, but medically unexplained symptoms, etc. I want to share two clinical vignettes. These are real cases that my fellow and I had seen, one on the outpatient side in an ambulatory CL space, and then one in the inpatient side. It's a lot to read, but I think it's important for us to just quickly get through it. The first case is a 55-year-old woman with past medical history of intractable focal left temporal epilepsy, 10 years in duration, referred to us by neurology. They were recommending surgical intervention that she kept delaying. Neurology characterized her as difficult at times, strong personality, and she initially presented as very pleasant, cognitively intact, though quickly transitioned into this very loud, agitated demeanor while discussing her experience with her illness. She became intermittently pressured in speech, though she was always interruptible, and she noted that seizures significantly affected her life, losing her fulfilling job as a teacher and her abilities to drive and advocate for herself. She felt very resentful towards family and friends, providers, and healthcare at large. So there's very diffuse sort of resentment, feeling misunderstood and even exploited. She added that she was actually abused after having a seizure in public, which led to some agoraphobic responses. So we'll talk about differential diagnoses in a minute. Review of symptoms, however, revealed anxiety, insomnia, depression, loss of appetite, irritability, or verbal aggression to others, but no overt psychosis or mania. And she also lacked some of the more cardinal features of PTSD, which we'll talk about in a bit. So think about this case. Ask yourself what you might do if you're encountering such, intense embitterment, if you will, or anger around illness and what it's done to somebody psychobehaviorally, et cetera, whether you would treat it differently, refer to a colleague, et cetera. The second case from the inpatient setting is a 61-year-old male with chronic COPD and asthma, congestive heart failure, chronic pain. So a number of issues. Also history of polysubstance use, admitted after a suicide attempt involving an overdose with alprazolam. After an initial period of delirium, he presented with high irritability, dysphoria, cited his chronic pain and estrangement from family as activating stressors, and adding that he really had nothing else to live for. He lacked any formal psychiatric history despite all of this, except for anxiety, basically, and demanded that he be on his alprazolam, 1 milligram 4 times a day right away, even after having had this, suicide attempt. He did not meet full criteria actually for MDD despite everything. And he also denied core PTSD, panic, generalized anxiety symptoms when we really look closely, manic psychotic symptoms. So they're probably more of a substance use disorder as described, but he spoke avidly about his experience as a veteran of some wars and about separation from family, portraying each with a strong theme of victimization, externalizing a lot. He felt rather angry and embittered about these experiences as well as about his arthritis, chronic pain, and as mentioned, externalizing often. So these are two caricatures that might seem very familiar to you. You might see this again, ambulatory and inpatient setting, just to sort of cement the idea that embitterment is at least a component of this, maybe not the full explanation, but certainly a component. So what is PTED? PTED, again, not in the DSM, and I'm not even certain that it needs to be. I'm just sharing the construct, is characterized by these criteria. I'm not going to go over every single word, but you see that some negative life event, it could be medical, it could be non-medical, has activated a cascade of these, embitterment feelings and unjust, experiences, that residue, if you will. No other mental health disorder, would explain it otherwise prior to that. And you do need 6 months duration of this, kind of like with PTSD and other DSM categories. Again, this is what has been proposed, not necessarily advocating for it or anything of that sort. The scholars that write about this write that there are embitterment subtypes, if you will. This might help us think phenotypically about what we're seeing. So PTED reaction, after one event, which is the previous definition. Complex embitterment stemming from multiple situations of perceived injustice. This might rub a little bit, up against demoralization, as we were talking about with prolonged hospitalization. Non-reactive embitterment in embitterment-prone personality, which is interesting. We don't have time today to unpack all of these different nuances, but maybe there is a personality subtype that is more prone to developing this. And then secondary embitterment in the context of some other mental disorders. So you can see there's obviously a lot of dynamic interplay between different factors if you consider this construct. And then, of course, there's diagnostic overlap. As is often the case in our field, we see individuals with 1, 2, maybe 3 different diagnoses. Here you have a Venn diagram just reminding us that we have adjustment disorder, PTSD, and then this other construct of PTED. And I'm not going to review all of the elements, but you can see some of the differentiating factors, but some of the overlap as well. Obviously, they share a significant reaction to an event. It's interesting that depression is in the middle there. I'm not convinced that you'll always have depression, but with these 3, but that's okay. So because this is a new construct, because I'm really just sharing it with the Academy and CL psychiatrists to add to the lexicon, we really don't know much about how to manage this, if you will. Obviously, there are many, empirically validated psychotherapeutic strategies for the person who has embitterment generally, anger issues, etc. But when thinking about this in our CL practice, especially if we don't have other resources, sometimes the MD is going to have to dip into their psychotherapeutic toolbox. And I'm just reminding the audience with this image of Glenn Gabbard's contribution during many of our psychiatric residency training experiences of the continuum of psychotherapeutic interventions, right? On one end, expressive ones, and on the other end, supportive ones. And if you can imagine somebody who's seething and embittered, you're going to probably want to have to hover over on the right side of this page with supportive statements, actually very much in line with the previous presentation, the second case that you presented. You're going to have to engage in some of that, validating and all of that. So one position that I'm going to just propose is that we leverage empathic validation regularly, obviously, with, quote, difficult patients, embittered or not, in our clinical setting. I'm sharing a case that I wrote once with a trainee where we had an individual who was in the hospital for very long, a couple of months after ARDS bout. And he was really sort of checked out, not engaging with too many folks, ruled out major depressive disorder, ruled out encephalopathy, but we knew that behaviorally something was going on. And we basically identified during this case that empathically validating, in other words, acknowledging, recognizing what the individual was going through, was a key to getting through that moment. And for those interested, I'm not going to read this script, but in the article, we purposely included the actual language that we used with the patient because it unlocks maybe some tips as to what to do with future patients. I'm going to skip because we only have a minute, but essentially we started the script by coming in as rote physicians and doing what we always do, the A&O times 3 dance and all of that. And we realized midway that the patient was very frustrated by us doing the same thing that everyone else does. And we caught ourselves and had to call that out. And he was very embittered by this process and feeling dehumanized. So again, in the interest of time, I'm only going to skip to a little bit of this, but right in the second doctor there where you see, he's actually, the patient is saying, Mr. L saying, it's not okay to do these tests, right? The same, tests, A&O times 3 again. And we caught ourselves and said, you're absolutely right. It's not okay. I just realized we're doing what we said is a big problem here, the repetitive tests. He says, yeah, we can't do that all the time. Whether it's the nurses or the doctors, they just keep doing the same thing, checking you here, examining you there. And then he adds to that, and pulling the sheets, the gowns, grabbing my arm, and we assist, right? Oh, the blood pressure thing. Yes. So you see how we're sort of in similar territory, validating the experience, and said, right, all of that, enough is enough. And then we said, we did the same thing you've been sick and tired of. And we know from our demoralization definitions, we love the terminology of being sick and tired of being sick and tired. That has to be extremely upsetting. That's the validation that it keeps happening. We don't need to do that exam, and maybe we simply talk, and that'll be best. And from here, since we're out of time, I can't tell you more, but what did happen, it was a turning point where he really started to embrace physical therapy and some other strategies to get out of the hospital. So it's very akin actually to the previous presentation in terms of how we use our language, perhaps our virtue ethics and our behaviors, but also psychotherapeutic principles like empathic validation to get through that embitterment and not necessarily characterize it as difficult, if you will. So future directions, I'm wrapping up. I do think this construct demands or deserves more research, particularly in medical settings. And we should, despite whether you use the construct or not, we should, of course, tailor our clinical interventions around the presence of embitterment, identify it, call it out, the sense of injustice, et cetera, and consider that impact on medical populations, and maybe reconceptualize our patients as embittered and not so much difficult, if you will. Obviously, training around this would be the next step after that. Thank you for your attention, and there's references here for those who are interested.